myself while I was in Vegas. Funny story, if you'll allow me. So, see this? Yeah. Right? Are you ready for a very embarrassing story? Women in here will understand. So, Mandalay Bay, which is where we stood, first of all, they put me on the 58th floor. And so, right? Of course, I was like, heck yeah, 58th floor. No. So you would think being that close to Jesus that I could get a cell phone signal. No cell phone signal. So, in fact, and then I had conference calls I had to participate in, and there's nothing more awkward than telling contract laboratories that they have to call the Mandalay Bay and then get transferred up to your room on the landline. So first of all, that was awkward. And then the night that, last night I was there, they had these really nice big tubs. And so like as a girl or a guy, whatever you're into, sometimes it just is nice to take a bath, right? So when you're a girl, you're like, okay, I'm gonna shave, right? So I did. Might have had a few cocktails. Anyway, long story short, doing the cocktails and the new razor, I scraped myself or cut myself, right? Well, I didn't notice that until I step out of the bathtub into the white marble floor at the Mandalay Bay, right? And I look down and there's this puff of blood, right? And I'm like, uh-oh. And the first thing I can think of is, they're going to report me to my boss. Like, my boss is an accountant. And they're going to be like, why is there blood in your hotel room? Like, I killed someone. And so, anyway, it was just a super awkward. Anyway, so I was able to get it cleaned up or whatever. Well, I traveled all the way home. Well, now I'm pretty sure there's cellulitis, like, around it because it's, like, inflamed and it looks like it looks like a horse with a giant laceration. And so now I'm going to have to go to the doctor and explain to them. Anyway. Because it hurts to stand on it. I'm sorry, that's probably more personal information. But anyway. So, note to self. What happens in Vegas stays in Vegas except for herpes and apparently lacerations. Anyway. Hopefully they don't have to amputate, like that's all I can think of, is it? No. Because that will just never be something I'll be able to live down. All from a little misfunction. All right, so local anesthetics. So local anesthetics are used very commonly in large animal practice. And this is because it produces a reversible loss of sensation in an area of the body without the loss of consciousness or alteration of CNS. And so in large animals, especially when we are not able to anesthetize them in the field, or if they just can't be anesthetized, if they're a cow, we are able to locally administer a drug to a nerve or an area to desensitize it, to do many procedures that we would otherwise have to anesthetize the animal. Not super common in small animals, just probably due to the ease of administration as well as maintenance of general anesthesia. The use of recumbency presents significant risk of trauma, myositis, ruminal tympany, and regurgitation. So again, reasons why you would select a local anesthetic over a general anesthetic. So the history of local anesthetics: cocaine is used as a surface anesthetic, as well as an analgesic. This is why when you see on movies and things like that, they rub cocaine on their gums, is because there's an anesthetic-like property to it. It has been used in ophthalmology as well as nerve conduction to minimize the flow of the nerve, as well as resulting in analgesia as well as anesthesia. It's successful with local anesthetic properties. The negative side effects as far as use was that it was toxic, and then they realized cocaine's a great drug, and the abuse potential in humans. But from that, they learned a lot of important things, and that's that the mechanism of action for local anesthetics is that it binds the sodium channels in the membrane of the excitable nerve cells. By doing that, it prevents the transient increase in permeability of cell membranes to sodium ions. This results in the decline in the rise of the action potential, and if you remember back from neuroanatomy, that the sodium is the driver of action potential. So if you block the ability for sodium to come in, then it'll decrease the transference or the upregulation of the action potential. This results in a slowing of the impulse conduction, ultimately leading to the decrease in the propagation of the nerve impulses themselves. So the character of the conduction block is depends on a few things. Number one, it's the penetration of the local anesthetic into the axoplasmic side of the nerve cell. So how well is the drug either administered, or how high of a volume is it been given around the nerve fibers in order to achieve penetration. Also, the length of the axon that's blocked. So if you are not super stellar in your application product of the product in the area, you will you may not get the length of the nerve covered that you need to, and the extent to which the nerve is covered to provide appropriate conduction block. How long or transiency of the block is dependent on whether or not it is a myelinated nerve. Remember that if it is a myelinated nerve, then the drug or the can only be effective near or enter at the nodes of Ranvier, whereas if it's an unmyelinated nerve, all of that tissue is exposed, and so the drug is basically bathing the nerve tissue itself. How well does it enter or leave via the sodium channels? So the more active the nerve, the more increased sensitivity it will be to blocking. So if it is a nerve that either isn't highly functioning or isn't commonly used for whatever reason, then it's not going to be nearly as sensitive as those that are very active and fires a lot. The structure and the chemistry of the local anesthetic is also very important. And those of you that are not fans of organic chemistry are probably cringing in your seats right now. But these are unfortunately important things to know and understand, so that you know why different formulations of these different drugs last longer. And when you are, depending on where you're going out into practice, you are going to want to know so that you recognize these names on bottles, because when the difference is whether or not you're going to get kicked in the face, or how long it's going to be before you get kicked in the face. It's going to be very important to understand and recognize. Those of us that have chosen to work on cows or horses, knowing how long your block is going to last when you're down there trying to suture up a laceration is very important. So structure and chemistry. So all of the local anesthetics are composed of three different important areas. The first of these is lipophilic. Remember that anything that's lipophilic likes fat. And this is represented right here by the unsaturated aromatic ring. There's a hydrophilic portion, and this is the tertiary amine, and this means that it likes water. This particular component of the molecules have ionic properties. They're also weak bases. And the aromatic amine and the tertiary amine, or if you're a chemist, you might say, no, I think that's just a mine, are linked by either esters here or by amides or amides, depending on how you want to pronounce it. So remember, an ester is a benzoic acid, and the amide or amide is an aniline derivative. We'll talk about why these are important in just a second. So esters are really, which are represented right here, are relatively unstable. They are broken down by plasma pseudopolymerase and have very short plasma half-lives. So any product that you local anesthetic or a depot injection of a drug, most commonly, it has a longer plasma half-life, and an increased risk of toxicity secondary to accumulation is present. But as far as when you're suturing up something you want and you need a longer duration of action, you want to choose a product that has an amide or an amide in its name versus an ester. Also, when you were comparing formulations of like Depomedrol can be found in both an ester or an amide, or understanding why different steroids last longer. A lot of that component has to do with its formulation. So this is something that I never learned in vet school, and it took me long into my PhD to find out, and I feel like it's important as far as for the safety of y'all's beautiful faces, so that when you go bend down next to a horse and try to suture it up, that you at least have an idea how long you have before fate intervenes. So the hydrophilic portion of the structure is it has an affinity for the axoplasmic side of the sodium channel. So The tertiary amine here is going to have a high affinity for the axoplasmic side of the sodium channels. So after you administer this product and you've infused it around the nerve, now we're talking about which parts of these molecules interact with the nerve in order to get the desired function. The linking portion, so this particular portion, aligns the lipophilic amine group into the sodium channel. So the length of the chain is important for potency. So the longer the chain of the linkage allows for better coverage of the sodium channels. So remember, if you have a better coverage of the sodium channels, you're decreasing the function of those channels better. You're having less of an influx of the sodium into the nerve, which facilitates a prolongation of the decreased conduction. So longer chain means more coverage of the sodium channels prevents more sodium from entering into the nerve, and is longer in its effective potency. Duration of action. So duration of action of the product itself is based on the strength of binding to the sodium channel. So how long the molecule will stay bound to the sodium channel, penetration into the axoplasm and that reaches the sodium channel. So that's based on the lipophilicity. So that's the first portion that we talked about, as well as how quickly the drug is removed. So that goes back to whether if it's an amide or a ester, how quickly is that drug degraded around where you have infused it. Clinical properties of local anesthetics, onset of action, so it depends on where you place the drug. So if knowing where and how you're going to use it, so if you were going to use it specifically around the nerve, probably should remember where that nerve is. Probably should have a good idea of anatomy of where it lies if it's a large nerve fiber versus a small nerve fiber. Concentration of the drug used. Now remember, if you have a small nerve fiber, say that you are going to anesthetize, you guys have had equine anatomy, right? And so if you're going to do a lameness evaluation and you're going to block out their feet, or at least the palmar aspect of the feet, you do a palmar digital nerve block, you probably don't need any more than, well, if you're Dr. Schumacher, you probably need 1 mil, but for the rest of us, you may need anywhere between 1 and 3 mils of lidocaine. You don't need 20 mils of lidocaine to block that horse's foot. Whereas if the further up the limb you move, or the larger nerve that you're blocking, you're going to need a greater concentration of drug. Does that make sense to everybody? Large fiber, probably going to need more drug to do it. The molecule size, so depending on what type of product you're using to administer local anesthetic, and knowing whether or not the molecule is a proportion that it's going to float away, if it's going to stay there, if it's, again, the formulation that's going to participate. The proportion of the cationic drug present. So the greater amount of it, when you look at the formulation itself, which the vast majority of you won't, and that's okay, but if you have a cation, remember those are positively charged molecules. The greater amount that there are positively charged molecules within that formulation, the increased amount, so the greater amount present will affect it, and then the increased amount of uncharged base available to penetrate into the axoplasmic space. Remember that in order to get into that axoplasmic space, you're going to need a lot of uncharged areas. Polar areas don't typically want to go into areas like the nerves. And so when you were looking at the proportion of cationic aspects of the formulation compared to the uncharged base, you want to have a lot of that uncharged base around to facilitate attachment and penetration. But knowing that the greater amount of drug present will also affect its ability to be effective. So peak plasma drug concentration, again, depending on the amount of drug injected. So remember, for the most part, we're administering these drugs in a localized location. But does it reach the systemic? And so honestly, that first and foremost goes back to the amount of drug injected. If you are blocking a larger nerve and you are giving more of a concentration, and especially if that animal is moving around more, you have a greater chance that there's going to be a detectable drug present in the bloodstream. The physical characteristics of the drug, whether or not it is rapidly absorbed into the bloodstream, whether or not you've administered vasoconstrictors. And we'll talk about this in a little bit, but a lot of times when you are trying to keep a local anesthetic in a particular area, you will administer it in combination with other drugs to keep it confined to that area so it doesn't go systemically. Site of injection. Location of where you deposit this systemic or this local anesthetic will also affect whether or not it's systemically absorbed. Does it make sense that if you are depositing this local anesthetic way far down on the limb, it's probably not going to, a huge amount is not going to be absorbed into the bloodstream. However, if you're higher up on the limb, a greater concentration that's been deposited, and you're randomly near a large vessel that has a big name that you remember from vet school, more likely to have systemic absorption. So we'll take a break from the chemistry aspect of it and just talk about uses for local anesthetics. So topical anesthetic, remember that it penetrates through open wounds, skin, or mucous membranes. And remember when you do this, either through the skin or especially the mucous membranes in the wounds, it will lead to significant systemic absorption. And intact skin is much more difficult to cross, but anytime, and if you think about when you go to the dentist and they squirt lidocaine on your gums prior to cleaning or anything like that, all of that is systemically absorbed and metabolized. And anytime that you are trying to suture up a laceration, this is probably my favorite thing to remind students of, is that you are more than welcome to squirt some lidocaine on top of the tissue that you're about ready to debride, or to, after you've done a local block. All of those things are okay to do because it's still going to be absorbed as well as to be effective on open areas or wounds. But also keep in mind that some of these have vasodilator effects, and so you can do that and have decreased sensation to the area, but you might also have a little bit an unwanted thing as far as increased blood flow to the area as well. So this is a picture injection of a local anesthesia into tissue independent of the course of nerves in the area. Bless you. So this is a laceration over the flank of a horse and extending into its hip. And remember that when you do a block, you always want to block above where the laceration is and extend it out beyond the wound edges itself. And you can do yourself a favor, a really big favor, because you only make this mistake once. You want to be high enough away from the wound edges so that you're not infusing it into whatever you're going to be suturing. Because remember, you are infusing that local anesthetic into that area, and you're going to, make a giant edema plaque, right, into that area. And so you want to get high enough away from the wound edges so that it doesn't increase the tension or cause issues as far as getting this closed. A lot of times this is used in reference to laceration repair, especially in large animals. For food animals, most specifically cattle, field block anesthesia injected across the direction of sensory nerve supply. This provides analgesia distal to the injection where it has been blocked. And so you can use a ring block for a limb in order to desensitize the area, or for instance in cattle, an inverted L block for the flank. These are very, very commonly done and good to keep in mind. Most specifically, those of us that are interested or want to do equine practice, using nerve block in the horses for diagnosis of lameness, injected in the immediate proximity to a nerve. This prevents passage of action potential. This particular technique blocks specific nerves or plexus, and so you're actually trying to infuse as little volume or little concentration as drug as possible in order to use it as diagnostically to detect lameness. But the same applies for if you were doing some sort of procedure as well. However, typically if you're doing some sort of procedure like laceration repair or probing an area that has either a penetrating wound, you're going to use a far higher concentration than you would for diagnostically. The other area where we use local anesthetic is when we talk about spinal and epidural anesthesia. And this is where injection of the product is infused into the lumbar dural space. immediately surrounding the spinal cord. And so this mixes with the CSF, and it blocks sensory innervation as well as sympathetic blockade in the spinal roots. The block is performed 1 to 2 segments rostral to whatever location that you're working on, and the preganglionic fibers are more sensitive to the lower concentrations. Keep in mind, anytime you are doing a spinal or epidural anesthetic, you need to be aware of species differences. Remember that certain species are far more sensitive to these local anesthetics than others. Most specifically, your ruminants are going to be more sensitive than, say, the equine patient. Formulation concerns. There are a wide variety of different formulations of local anesthetics. We are most commonly aware of injectable, so sterile solutions for parenteral use. However, we cannot forget that gels, ointments, as well as aerosol sprays are very common, and there are transdermal patches. Keep in mind that any of the injectable formulations can be applied to either a mucous membrane or an exposed wound, and you can get the same effect. Know that. So that if you are in a pinch and you don't have any gels or ointments, you can pull up 5 mils of lidocaine and spray and apply it over the affected area. Those of you who have not had the benefit of tasting lidocaine, it's pretty nasty. So if you go squirting it into an animal's mouth, just know that they're gonna, unless they're anesthetized, they're gonna have an adverse reaction. It's pretty bitter. When we talked about earlier about administering a vasoconstrictor in combination with a local anesthetic, when we talk about that, we're most specifically talking about giving epinephrine. And when we give epinephrine in combination with lidocaine, it actually causes significant vasoconstriction around that particular area. And so by doing that, it holds, you stop the blood flow from going to that area. It really holds the local anesthetic in that particular area, stops the blood flow access to the area, so decreases the metabolism of the local anesthetic and really facilitates it hanging around longer. Potentiating additives, so increasing the depth or duration of local anesthetic blocks. Specifically what we're talking about here is looking at intrathecal as well as epidural injections, and you can add in an alpha-2 agonist, an opioid, or potentially ketamine into these combinations to facilitate their activity. Things that you need to be aware of is that inadvertent intravascular injection will cause tachycardia if it's used in these combinations. Preservatives. When we talk about administering things in the CSF or the intrathecal space, you have to be mindful of the fact that a lot of the multi-dose vials, or all the multi-dose vials, contain preservatives, and those are the names of all the different preservatives. These can provoke allergic reactions, and so there's been multiple human case data that has reported this, and so if they have an allergic reaction, which potentially can be also seen in animals, it will cause both acute and chronic neural damage and nerve root irritation. So if you are doing an intrathecal administration, you want to use a preservative-free formulation. So in your practice, you will have ones that are multi-dose vials, which is fine for administration in a local area or anything else besides doing it intrathecally. But if you're going to use an intrathecal, you need to use a preservative-free to avoid the risk of an allergic reaction that would cause acute and chronic neural damage.
I have a question.
Yes, ma'am.
Intrathecal is in
Intrathecal is in this CNS. If I were to ask you what the major side effect of using local anesthetics would be, I would want you to tell me neurotoxicity. It's a generalized descending CNS depression, and is proportional to the amount of free and circulating unbound drug. So if you were to overdose your patient, say you got a little bit heavy-handed and you gave it way too much drug, it would be proportional to the amount of excess drug that you gave as far as how progressive the neurotoxicity would be. The clinical signs are dose-related, which should make sense. If it's just a little bit of neurotoxicity, you might see muscle twitching. Depending on where it is and the amount of it is, it might progress to myocardial depression and seizures, which ultimately leads to unconsciousness and apnea, and finally collapse and death. So these medications are not, giving them are not without significant risks as well. The risk factors associated with toxicity, number one, more than anything, is the dose. So more often seen in smaller animals where the mg per kg restrictions get overlooked. So always, 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 no matter if it's a dog or cat or foal, be aware of what the toxic dose should be. Also in the ruminants, very specifically, who are more sensitive to these, be aware of how much the dose should be as well. The site of injection, increased vascularity means more rapid uptake into the systemic circulation. So if you are giving it near a large vessel that has a name, and in some species makes noise when it's lacerated, so be very cautious of the fact that those large vessels have greater risk of absorption, and then we will have more systemic exposure. So in order to avoid these, so keep the dose, limit the dose to keep the concentration low, so only use what you really think you need, and limit up the absorption of drugs. So local anesthetic administered around the site of infection or injection, excuse me, and so make sure that you are really keen on where you're putting it, how much you're putting it, and not being overly aggressive with it. So cardiotoxicity is another toxicity that you can see. In some of these patients, you can see dysrhythmias as well as hypotension. Most commonly hypotension, you will see depression of the myocardial contractility, direct relaxation of vascular smooth muscle, as well as the loss of vasomotor sympathetic tone. So again, if I were to ask you what the most common toxicity seen with local anesthetics would be, I would want you to say neurotoxicity, and the things the way you would avoid it would be using the appropriate dose and knowing where you're putting it. So drug interactions, when I talk about drug interactions, lidocaine is one of the drugs that we have really turned to use in combination with our anesthetics, both inhalant as well as injectable, because it decreases the amount of inhalation anesthetic needed. And it has been studied extensively in dogs, cats, and horses. And so many practices, especially referral ones that are doing emergency, will use lidocaine as CRI for injectable anesthesia in combination with their other drugs. And so what they have found is that lidocaine just is a really nice balance and helps minimize the amount of effects that you have to use of other drugs. For regulatory issues, things that we need to talk about is only mepivacaine and proparacaine are approved for use as local anesthetics in animals. The rest, as veterinarians, you are using off-label. Any of the local anesthetics are Class 2 substance and determined as Class 2 substances by the Association of Racing Commissioners. Animals testing positive post-race are subjected to penalties. Also keep in mind, any of you that are going into sport horse work, especially ones regulated by the FEI, animals that cannot compete with lidocaine on board, and so if they do undergo a laceration, they have to be removed from the competition if you're going to have to use lidocaine as a local block to repair it. So some of the, especially like the 3-day eventers that will tear themselves up on cross country, if they want to compete the next day, then it becomes a very interesting laceration repair, trying to do it without local anesthetic. So we'll touch briefly on some individual drugs that you will need to know for the sake of the exam as your model drugs. First of which should not be of any surprise to you, though it is going to be lidocaine. It has the greatest diversity as far as routes of application. It's the best local anesthetic for infiltration for use. It is a Class 1B antiarrhythmic, so in other courses such as surgery where you talk about GEV, this is a drug that is used as a CRI, either intraoperatively as well as postoperatively to help stabilize the heart. You also probably talked about it in this class when whoever taught you cardiac drugs. Cough suppression, lidocaine is a good suppressive of the cough reflex. And then as far as surgery, we often use it as an anti-inflammatory. It has been shown to have a systemic effect as far as on the GI tract as being an overall anti-inflammatory. And so in that particular aspect of it is used as a CRI as well. Bupivacaine is the most long-acting amide Again, remember, we're going back to the first few slides of this lecture, it is an amide, so it's going to be broken, have a longer half-life in the tissue in comparison to lidocaine. Its uses are extensive. It's used for nerve blocks, can be used in both, any species, most commonly equine and bovine. It can be used as an intrapleural administration, as well as spinal and intrathecal. Again, because of its chemical formulation, it has a longer half-life than lidocaine. And so if you are looking at having to do a longer procedure where you are going to need to have more time, this would be a drug to select over lidocaine because of its chemical structure. You need to avoid injecting it intravenously due to toxic side effects. That is something that is limited as far as its use. The last drug that we're going to talk about is proparacaine. It is fast acting as well as shorter duration. And when you compare it to tetracaine, and it's approved for topical use on the cornea. By using it, it helps minimize corneal irritation as well as providing topical anesthesia to the cornea as well as conjunctiva. Proparacaine is the go-to for using it in diagnostic procedures and in ophthalmology, as well as the therapeutic manipulation. And so this will be your friend and a product you reach for should you decide to, or when you are doing ophthalmic procedures or examinations in your practice. All right, do you guys have any questions on local anesthetics? Yes, ma'am.
Can you repeat the situation where you would use bupivacaine over lidocaine?
Sure. So bupivacaine, and it's a newer drug, and I would choose bupivacaine in things where I need a little bit longer time. And so that because of the chemical formulation, it will be more effective in tissue longer than lidocaine. The reasons why you don't use it in comparison for lacerations most commonly is it's more expensive. And so in a lot of practices, you're going to reach for lidocaine because it's like $1 for a quarter-liter bottle or something. So you can infuse that, whereas bupivacaine, you would need a little, it's more expensive. However, it is used in situations like laparoscopic procedures where you're going to need 45 minutes to an hour, but at that point you're talking about charging $1,500 to $2,000 for a procedure, and so the increased cost of bupivacaine would be warranted. Yes, sir.
Going back to your laceration repair, what you said about make sure you lock high enough so you're not causing, do you mean closing to cause edema? Is that what you meant?
Right, so when you look at, that's a great question. So depending on when you guys go out into practice and depending on your exposure level of what you have seen and what you get to suture up or have sutured up. When you see something like this in private practice, even if it's on a small animal, you're going to freak out a little bit. So my point is when you locally block this, see how this individual, she is probably 1.5 to 2 inches away from that skin edge, and that's where you want to be because you are infusing a bunch of liquid right into the tissue. It's local anesthetic, but it's a bunch of liquid. When you do that, you are making edema in that tissue. Does that make sense? And so if you do it right along the skin edge where you're trying to close, it's going to be infinitely harder for you to close that. So if you go 1.5 to 2 inches away from where you're going to close, you can confine that local block into a nice area while still leaving you a nice skin edge to pull it closed. Keep in mind, anywhere you put that local block, you're going to cause some increased blood flow to the area, some vasodilation. And so the last thing you want in a laceration is more blood in the area. And so if you make it just far enough away so that you minimize those two things, it really will facilitate closing it better. And you will learn, just a practice tip, if you infuse a little bit in a line, then you can, go to the depth of the needle, pull the needle out, and then stick it back in where the anesthetic is so you don't have to stick them again and they don't feel it. So there's a lot of different ways, but that's my biggest thing is just make sure you're away from that skin edge. It'll make your job a lot easier. You're welcome. Any other questions? We can use the rest of this time if you guys want to do a review, but I doubt any of you have even looked Unless you guys have burning questions that you can think about. Y'all are like, no, got nothing. Yes, ma'am.
Whenever you're giving lidocaine and epinephrine, which one do you give first?
You can give them in combination.
Oh, okay.
It's in the same syringe. Any other questions? All right, well, it has been a pleasure teaching you guys, and I will see what I can do about getting a hold of the exam and making you guys a study guide, and then send it out to your class.
Thank you.
Thank you.
Good luck the rest of your semester, good luck